Hi, everybody. Good afternoon. Thank you so much for joining us today. My name is Nicole Locke. I'm the current education chair and the director of the job search series this year. I'm really excited to be joined by our speaker and panelists today. Today, this is going to be on the private practice job search. Please feel free to ask any questions throughout the chat. Throughout the presentation today. Just some reminders is that this session will be recorded. It's going to be uploaded to the TCAN YouTube channel within the next week, and the link will be sent out to anybody who has registered. Please check out our previous sessions on our YouTube channel, and please register for future sessions if you have not with this QR code. I first want to introduce our moderator today. Um, if you want to forward our slides. Um, This is Shubham Bakshi. He is going to be our moderator today, and we're so glad to have him. He did medical school at Northeast Ohio Medical University. His residency was at Bay State Medical Center in Massachusetts with his fellowship at Tufts. His current job is through Pediatrics Medical Group of North Carolina, and he currently works in a busy 70-bed level NICU, level 4 NICU. So thank you so much for joining us, everybody, today. We look forward to this session.
Thank you so much for having me, Nicole, and thank you so much for TCAN for this excellent opportunity. I'm going to now introduce Dr. David Forst. He is our didactic speaker for the session. He did his medical school at Baylor College of Medicine. He also did his residency and fellowship at Baylor and Texas Children's Hospital. He currently works with the Pediatrics Neonatology Group of Houston. He is as you can see, he wears multiple hats and multiple positions. He is the practice director, Pediatrics Neonatology of Houston. He is HCA National Physician Advisor for Neonatology. He is the NICU Medical Director, the Women's Hospital of Texas, and he's the Chief of Staff at the Women's Hospital of Texas. So thank you so much, Dr. Horst, for this wonderful didactic speaker. And we are looking forward to learning from you.
All right, thanks for having me, everyone. I participated in one of these a couple of years ago and really enjoyed it. It's a great opportunity to meet some of you folks early in the career. I want to keep it, I don't even have slides. I'm going to keep it very general and just kind of lay out sort of the structure of what private practice looks like. As you can see, I was a Texas Children's lifer for the time I was there. I also was an attending at Texas Children's for 4 years before I then left and went into private practice. Went to a pediatrics group up in Denver and then came back down to Houston about 6 years ago. As you can see, there are lots of leadership opportunities in private practice. If you spend enough time, I'm now full circle talking to you guys looking to shed some of these titles to some of our up and coming younger neonatologists. Our group itself, so I'll kind of lay out what our group looks like. It's a good example of a big private practice group that's owned by a physician management group. I think you all are familiar with pediatrics. And within it, we have a bunch of different kinds of jobs, which are a good way to describe it. It still doesn't cover everything, but I'll just kind of lay out the whole landscape. So we cover, so Houston, all the cities are different. It's going to be different over city. In Houston, about a third to 40% of the city is Baylor Texas Children's coverage. We've got UT Medical School here. They're covering probably about 30% of the city, and then we're covering about a third of the city in a private practice model. We have 60 neonatologists, about 100 nurse practitioners, 15 peds hospitalists, and PNPs seeing newborns. We're in 16 sites. We have a developmental follow-up clinic that is staffed by PNPs actually doing the exams, not full developmental pediatricians. We do some clinical research. Kashif Ahmad, who some of you may run into, is heading most of that up. Last year, we saw 272 NICU patients every day and 250 well newborns across all of those sites in a bunch of different environments. We'll talk a little bit about what day-to-day looks like, but first, in general, just to see where we slot in. For private practice, you have an employed model, which is most of what's going on out in the world right now. Most of the employment is going to be either a physician management group, may or may not be a public company, The one that I work for is Pediatrics Medical Group. I think most of you are familiar with it. Pediatrics covers approximately 28% of the NICUs in the country now. It's gotten to be a fairly big group and one of the survivors of all the physician management groups. Those of you who don't know, and all this is very, I'm speaking to you as just a physician. Actually, probably my biggest motivation right now, I have a son who's an intern right now, and a daughter-in-law who's a second-year pediatrics resident at Northwestern right now. And I'm kind of putting myself back in their position and thinking how I had zero knowledge. This also dates me, no internet when I was coming out either. So we had no way to find out. If you can't even imagine what that's like, you have no way to find out what the rest of the world looks like, what's going on. Now I think there's a lot more information out there. So most of the, so what I was going to say is Envision has recently gone bankrupt. That was the other big group that you might be working for. Just as recently as a week ago, their women in services, their physician management group that did surgery and some other things, but their women and children's services just kind of got parted out. Some turned into hospital groups, some got bought by pediatrics, and some by some other groups. So pediatrics is still a big one in the country. There's still other ones. You can work for a hospital, be employed by a local hospital, a larger chain, HCA, which is the biggest chain in the country, does not employ most of their neonatologists, but they do in a few sites. They have 183 hospitals, and they do in 4 or 5 of them. You still may be in a private practice model working for a university. There are 2 sites I can think of that are a little atypical. Dell in Austin is run by UT essentially, but the pediatrics group runs their NICU, and then have academic titles as well, but still run in a pediatrics model. Same thing is going on in Colorado Springs, where the university bought what was a city-owned hospital, has about 10 neonatologists there, and rather than replace those neonatologists, they just hired them on, but they still work in a private practice model. There are large multi-specialty groups that you may work with, and those can have all different types of ownership. There are multi-specialty groups that are sort of turning into part of the newer model that's happening, which is actually working for the insurance company itself. So a large multi-specialty group in Houston called Kelsey-Seybold just sold themselves to United Healthcare, for instance. And the other model that would be similar would be working for Kaiser out in California. I don't know as much about how those models work, just what the employment's like. Something that there is less and less of, though I know it exists in various pockets, are physician-owned groups where you work towards partnership. Most of those groups have sold their equity to either a hospital or a large group like pediatrics. And once that's gone, then it's pretty hard to go back to another model. But there are lots of groups out there. I don't know, last time we had somebody on the panel who worked for one of those groups. I know a lot about how it works, and we can talk about that. But that there's less and less of that that's available. It has some advantages. And then there are some people that go out and work in a locum tenens environment. So if you don't have a lot of reason to be in one place and you want to go around and experience what a lot of other units are like, it's very instructional to drop into a different unit if you kind of been in the same place. I was the prototype of that. I only knew one way to do things. The more you go around to different sites and meet other people, I think you grow a lot as a neonatologist. So I thought the things to think about when you're thinking about a schedule, first off is what the call looks like and how much there is of it. There are anything from smaller groups where you might be on call, more like residency fellowship, where it's every 3rd, 4th night. There's not much of that anymore. Most of the call in private practice goes to about once a week. And that's what it's been most of my life until I moved back to Houston. And then that call can either be call from home or in-house, depending on the size of the unit. The larger units, once a unit gets up past about an average daily census of 30, maybe 40, in most places, and lots of variability, you're going to get into a situation where the hospital is going to want you, or you're going to decide that you need to take call in-house, and that's a totally different model. So that's sort of one split. If you're comfortable walking around, living your life, and then having to be ready to take a phone call and maybe have to go into a hospital for a delivery, you have typically a better schedule but you're kind of doing it all the time instead of leaving your work with more shift work and going home. Out of service time can vary, and I can tell you a little bit about what that's like as I describe our group. The amount of administrative responsibilities that you choose to do can vary as well. We have everything in our group from people who like to just come in and be a neonatologist and go home and not have any responsibility afterwards, to people who are very involved. We are hospital based. One of the reasons I chose this job is because the outpatient world I find very frustrating. Trying to arrange to have 30 people show up over the course of the day and meet you in a room at the same time and schedule all that, versus us, we get to go in. I brag about this all the time to all the people I work with in the OBs. So imagine you just get this whole bunch of work. You walk in. First part of the day is kind of stressful because you're trying to prioritize what you can do. But barring any emergencies, you do it on your own time through the course of the day, choosing how you want to do what when. So the administrative responsibilities, really, you can pick and choose. Lots of jobs where you can just be a neonatologist. And then things throughout the day to think about are, it took me a while to figure this one out because I never took the first call on anything. I was at Texas Children's, where there's layers and layers, and as an attending, I was like the fourth person that would get a call about anything. And then when I was working in Colorado, I had NNPs all the time. So whatever team, every team had an NNP. So when the nurses had issues, first person they called was NNP. I couldn't figure out why when I got to Houston, I was getting so frustrated every day. And it was because I had a team without an NNP and I was getting every call about everything. And that was okay. I got to know the nurses really well, but it's a very different level uh, I don't know what word I'm looking for. I didn't want to say frustration, but it feels very differently. So whether you have NNPs or not makes a big difference, especially when you're taking call from home. And then what other ancillary support you've got around you. Most hospitals, even the smallest ones, are pretty good at having all the things, dietitians and RTs and pharmacists and all those things, because all the hospitals have those. Last thing that I would say to consider, and then I'll just describe a couple of jobs in my practice, is your contact with other neonatologists. So I have always worked at big units where more than one neonatologist is on during the day. That's very different than working in smaller units. So there's even level 3 units that have, say, an average daily census of 25. You may be the only neonatologist there during the day, and you may be taking call from home. Your checkout to the next neonatologist, it's not like you're going to be in the house all night and meet that person and talk about stuff and then go home. Your checkout may be on the phone. I have neonatologists in my practice who work in fairly busy level 3 units with an average daily census of 20, who can go a whole year without seeing another neonatologist, absent whatever social events that we have. It's just a very different environment than what you're used to now, where you're surrounded by people and doctors and everything all day. So in my practice, I'll describe a couple of things. That there's a variation. We cover a unit in Lufkin, Texas that's remote. And so I've got a doctor there who is on call 24/7. She actually chooses to work more than half of the days of the year. So the way our practice is set up, if it's an average daily census that's single digits, we have 2 people and they each cover half the schedule. It's up to them to figure out how they cover it. So you're on call from home 24/7 for about 15 days a month or half the year. It also means you have half the year off if you think about it. And if you have a good working relationship with somebody else, you can use that time very wisely and have vacations. We have a lot of folks in our practice who have family overseas and they make international trips for 2 or 3 times a year that they can take a 2 or 3 week vacation in a row. And that's another thing to think about on the schedule is, how long can I be gone before I come back? So can I take 3 weeks off to go back and visit family? How many times a year can I do that? This particular position, she would work she basically worked both FTEs because she had a ranch up in Lufkin, enjoyed living there. Average daily census of 5, and she didn't have any problem getting called in anytime because she was part of the community and it didn't happen a lot. And so she basically got paid to work 1.5 jobs because she was willing to do it. And worked up there for about 10 years, covering the unit all the time. The key to that was having an NNP there. So there's another small town nearby, which shall remain nameless, where they cover a unit similar size but without NNPs. In that case, you have to get called in for anything that happens, any bad baby, any unusual delivery. If there's hospital policies, you have to go to meconium deliveries, then you're going to be getting called in for all those deliveries, for instance. And also, it's very difficult to walk out of a hospital without an NNP there because you're going to have to train up and or trust your nurses to cover, or you're going to get called back for a lot of stuff too. So that's a little bit of different environment. Those docs work about a third of the month because the call's a little bit more burdensome. I've got another setup in Conroe up north where average daily census of 7, nurse practitioner there. They're responsible for 7 newborns on average a day and about 7 NICU patients. Call from home half the month because of those numbers. You probably spend 2-3 hours in the hospital a day taking care of stuff. You might do circumcisions and those kinds of things. Again, key to have an NNP there. It makes it a lot more manageable. You get up to Clear Lake is a level 3. It's got average daily census of they're up to about 30 now. That's doc in-house 24/7. So we have 6 doctors there. There's 2 doctors there every day. And then they do the day. One has the kind of easier level 2 job. One is doing the more acute kids in level 3. And then the doctor comes in at night at 5 o'clock and then stays, or 6 o'clock there, and stays over until 8 the next morning and checks out. So we have 24/7 coverage. Nurse practitioner the whole time. Again, very different type of job because you're in-house. When you walk out of there at the end of the day, you typically never have to come back. Now, flip side of that is you always just do the math really quick. There's 6 docs to cover that schedule because they're each working half of the month. So you got one of each of those shifts for 5 days of the month. The kind of short one, the long one, or the night one. That means you're going to be working 5 nights a month. So suddenly you've got in-house call a little more than once a week, which is a very different setup than out-of-house call half the month or something like that. I've also got busier level 3s that were out of house where they only work 10 or 12 days a month. And again, those are ones where they get called in a ton and they often might have to stay there all night and then work the next day, but they get 20 days a month off, which you can add up pretty quickly for the year. That's a schedule that you can have a pretty healthy family life with. And then we've got a place like Women's where we have 110 patients a day, 8 doctors there a day, somebody in call overnight every night, along with 3 nurse practitioners. That's a model more like what you all are used to in an academic setting. The trick though, this is things to look for though. The trick though is it takes us 22 doctors to cover Women's for all the stuff that we do. So even with 2 doctors there a night, that's call 1 in 11. Which is very different setup too. So all things to consider. One comment on when to start looking. I think in general, with recruiting for a practice this big, we typically, the fellows are starting to really get active and do a lot of the interviewing in the fall of their third year. My experience has been that almost everything is decided by the holidays of that third year. So I don't think you can ever start too early. I have always been impressed by folks that show up sometime in their second year, looking and inquiring about jobs. Some of the most organized folks that I have met have been the ones that have shown the interest that early. And honestly, I want people to work in my practice who really want to be there. At this point, we don't really want folks we don't want people to come in and be unhappy. We want folks that really want to work here. If I've got somebody coming, 2 years before they start and saying, I really want to work at this practice, that really tells me a lot. So if you're, what time of year is it? If you're a second year fellow, now is about the time that things start to get rolling as you roll into the summer. And then all of the interviewing and everything typically happens summer into fall. There is another cycle of experienced neos that are moving from practice to practice because of life changes or other things. Most of the time that revolves around kids. So most of them are sort of a second wave of folks that find out about the life change and are looking for things in the spring. And there's a few things that happen at other times as well. I asked our recruiters for pediatrics where they post jobs, and I got a long list, and I'd be interested to hear from some of you guys where it is that you go looking these days. A lot of it is networking and word of mouth. There is nothing that we get a lot of resumes from people that we don't know. Our world is a small one. I just have to say it's very different than a resume that is a friend of a friend, or somebody that we've met at a conference, or somebody that we know really well. The networking goes a long, long way, especially to getting you in the door and getting an interview. I've got a whole list: career MD, MD search, PEDS jobs in AAP, health careers, hospital recruiting, neonatology jobs. There's a pediatrics career page, Doximity, Glassdoor, Google, Indeed, LinkedIn, Practice Match, and the New England Journal. That's the list that they gave me where they're actively putting things out. I'm sure you guys are a little bit more facile than I am with knowing where all that shows up. Compensation in general, just one comment on this and we can have more discussion, but I'm not really going to use numbers for the discussion, but just general forms of compensation. Everybody, so if you're employed, you're working for a salary. There's always benefits that go with it. Benefits are pretty similar for larger groups, like larger companies like pediatrics. My wife actually is Baylor faculty. I know that the benefits are pretty much exactly the same. And I used to work for them too, so I know that. The difference is there are some practices that have an incentive or a bonus structure, and it's reasonable to talk with folks about that when you're interviewing. One comment on talking about money when you're interviewing is the people that I want working for me are the people that are comfortable talking about those things. If somebody wants to negotiate or says, can I get a bigger signing bonus, or can I get moving money, or I've got a salary here. Some people might feel like they're bothering the folks by doing that, or I'm going to be a pest, or that's going to be perceived of in a negative way. It's actually the opposite. The people that I want working for me are the people that advocate for themselves, who know how to have difficult conversations. The rest of life is all these kinds of things. And the people that we want around us in our group, I want to have people who are very comfortable having those kind of conversations. The salary, signing bonuses, those kinds of things are all somewhat negotiable. It's fairly set these days to where we don't, especially if it's a larger company. If you're negotiating with a privately owned group that has their own equity, and that's the key. It's a group that hasn't sold their equity out to anybody else. Then you also need to, you probably have more room for negotiation. And part of that negotiation should include at what point do you get some of that equity in the group, and how quickly does that happen? That's going to be variable. And if we have anybody on who is part of those groups, I know some about it, but I'll defer to them how that works. But that's a key difference. There are not a lot of jobs out there that still have the equity available to acquire as part of your tenure with the group. There's a lot of advantage to that as well, but you really want to make sure when you're vetting out a job that you're not going to get hired to a group that's going to sell before you get that equity. You can't 100% avoid that, but that's another thing to always look out for. And be clear about what it takes to get that equity. I've got a few other things to consider here, but I'm just going to leave it at culture. You've done a lot of work to get to this point, and you're going from a place where you've been changing jobs every 3 years, and within that job you've been doing different things every month sometimes, until I guess fellowship. But even then you still have some variety and you're moving around from different parts of the practice from time to time. But now you're going to have a job possibly for life. I've had, well, I take it back, 3 jobs for 2 companies. It's been 26 years now, and I've only had 2 times where I've changed what I'm doing, and it's been mostly the same thing. What makes or breaks the job are the people that you work with. When I'm recruiting for people. We're all pretty good neonatologists. Once I've established that somebody is a competent neonatologist, I don't need a superstar genius neonatologist. I need somebody who's not going to make my nurses angry and who it's fun to sit in the workroom with, and maybe go out to dinner with afterwards. We want people who really enjoy working together. The goal of telling the whole group this the other day. The goal is to have everybody wake up in the morning and kind of look forward to going to work. Of course, you're going to miss your family and you'd rather stay with them most of the time. But I want people to have a really fun time with their job and at work and with the people around them. So um, as much as you can vet that out, if you come interview with us, we're going to have a really nice dinner and all have fun, and it's going to appear like we all get along. We actually do. How you figure out that people are getting along is asking lots of questions, and making sure when you're interviewing that you're not just interviewing with one or two people. If it's a smaller group, you really should spend time with everybody in a one-on-one setting and ask a lot of questions about what it's like to work there. Um, and if you're in a larger group, make sure that you may not be able to meet everybody, but make sure that you've met enough people and try to figure out a way to meet with somebody that wasn't necessarily on the interview list. So they may be out of town, but you always want to make sure that they aren't just cherry picking who you meet with. I think as much time as you can spend on that, that would be one of my main points of advice. And I think with that, I'm just going to leave it and we can have some questions and talk to the panel if that's a good start for us.
Yeah, that does sound great. Thank you so much, Dr. Horst, for a wonderful introduction to what is a looking like a fabulous panel we have for the private practice job search series. So now I'm going to introduce the rest of the panelists. Our first panelist today is Dr. Matt Pellerite. He did his medical school at Wright State University and Boonshoff School of Medicine. He did residency at University of Chicago Comer Children's Hospital, and that's where he did his fellowship. He is currently at Endeavor Health. It was previously known as North Shore University Health System, and this is in Evanston, Illinois. He is the division head of neonatology. He is the medical director of the Level 3 NICU, and he's a co-PI and on an NIH R01 grant. He's looking at the impact of antenatal stress and placental pathology on childhood development trajectories. Our next panelist is Dr. Ann Smazal. She did her medical school from University of Iowa. She did her residency at Baylor College of Medicine, Texas Children's Hospital, fellowship at Northwestern Lurie Children's Hospital, and currently working in Milwaukee and surrounding communities. She is the attending neonatologist. Our third panelist is Dr. Jenny Koo. She did her medical school at University of California, San Diego, residency and fellowship in the same location, University of California, San Diego, and currently working at California Sharp Mary Birch location, currently working as the attending neonatologist. And we have Dr. Ravi D. Cruz. He is I personally know him, so I'm very excited to see him too. He did his medical school at Brown University, residency at Hasbro Children's Hospital, fellowship at Women of Infant and Children at Brown. He currently works in Seattle, Washington, and currently works as a neonatologist for the Pediatrics Medical Group in the multi-center location there. That being said, we are going to open it up for question and answer. Feel free to chat privately to me or even publicly and send in any questions that you may have. We are happy to discuss some. Some of the questions that had already come in earlier, and we are going to begin with first one. How different a job search is between private and academic center? And we are going to begin with Dr. Pellerite. If you can answer that question, we would love to hear your thoughts on that.
Yeah, sure. Hi, everyone. Thanks for having me. I think Dr. Horst did a nice job of laying out a lot of groundwork because I think that sometimes we get stuck in labels around what is an academic and private practice. Like there's this line that divides the two of them. And in reality, you look at my position and, we are by every measure, a community-based hospital system, but we have an academic partnership with the University of Chicago, and I have a clinical academic title with them. But we have an independent research arm that funds, the pilot grant that led to my own R01. And so I don't think it's necessarily like this hard and fast dividing line that those are different. I do think there's, different structures in place within lots of positions that would that I would want to be thoughtful around if I were applying to a job. But I think one of the drawbacks to a lot of the fellowship programs is that exposure to what some of the work models look like that Dr. Horst was working through, like, are just very limited. And so understanding that can take a lot more time and independent kind of work to do that. So I guess I would say that when you're thinking about the difference between kind of practice settings, I would just know a lot about where you're planning to apply and why that's interesting to you. I think, to echo what Dr. Horst had said, I'm most interested in someone that wants to be a part of our program. And so that also lends itself to understanding a little bit about what that's like, understanding what at least what they think that's going to be like, and why we can talk about sometimes those expectations are mismatched or well matched. And so, I think that you'll get lots of great advice from the faculty at your institutions about applying for formal academic positions that have a lot of requirements around who they bring on to the team and in certain niches. I think one benefit of the models that we're talking about today are the ability to navigate positions that fit you and what you want to do. And so, one of the reasons I put all the things that the roles that I have, and I think I appreciated that about Dr. Horst's introduction too, is that, like, there are a lot of ways to navigate a career path. And so understanding what that might look like for you and what you want to get out of that is probably the most helpful part to start that process, and to think what values do you have? Where do you want to put those into action in practice? And whether that's, a goal around clinical care, and there's some patient population that you're very passionate about. That's awesome. If you have, research interest, or you have QI interest or leadership interest, I think a lot of people think about the difference between private practice and academics in terms of education and participation in that formal process of medical students, residents, and fellows. But I would argue that today's workforce, as Dr. Horst aptly pointed out, includes NNP providers that are, very different in their skill set. We interviewed someone recently who was completing school and had never intubated and put in UVC lines, versus people that have 20 years of experience and can outpace most of the neos, including myself on this call, around delivery room resuscitation and procedural skills. And so I think being a part of that education process for NNPs, we're talking about a PA fellowship program in neonatology. Like, there's lots of ways that trainees in the future need to take care of these patients. And so I think that can be something that people can include in that practice. I'm going to stop there. I've, talked too much. So I think I answered some of that question.
No, thank you so much. We loved hearing all perspectives on that. And again, please feel free to send messages and send in your questions. One next question we had is how to talk about future work, especially if you're not exactly sure what you want to work on. And I will let Dr. Smazal answer that question. We have some people who are interested in working in private practice, but they are not exactly sure what they want to work on, particularly as they're part of QI projects or future administrative roles and stuff like that.
Let me unmute myself. Thank you so much for having me today. I think there's a number of ways you could take that question, and especially if you're kind of uncertain about the direction you want to go. I think that coming out of fellowship, if I were interviewing a candidate for a position in my group, I wouldn't really expect someone to know exactly where they want to go. I think it would be more than enough for you to know what you've loved about your fellowship, what you've been excited about in your fellowship, and what really excites you about working in the community. At least in my group, we are in a community practice. We're taking care of children in multiple sites, both urban and rural. And I think I would just love to know what it is about my group that appeals to you, what you would be excited about in working with in the future. And we can figure out things like QI leadership roles in the future. But I think coming out of a fellowship, the ways that you're pushed in any fellowship in neonatology are going to be in a number of ways. So you may have held leadership positions, QI roles, research roles, all that kinds of things. And I would love to know what it is about my group that appeals to you, and what you've been excited about in fellowship, and how you want to grow as a neonatologist in the future.
Yeah, no, that's definitely very true. And our next question is, we have somebody who is applying across the country to California to be closer to family, but they don't have any other ties there. How can they get more inside information from private practice groups there? And what if they can't get any? What are ways you can sense during an interview that colleagues honestly enjoy what they are doing and who they work with? And I will let Dr. DeCruz answer that question.
Sure, that's a little difficult. I think it is a lot of it is the sense that you get on your interview day, talking with the people that are there, and also how engaged the whole group is on said interview. We have a group of about 20 neonatologists, and I know just about all 20 were engaged in some part of my interview when I came to apply, and I think that spoke volumes on how much they were invested in bringing in a new member, and what they wanted to see, and also what they asked me about, sort of, what are my interests outside, what's my family life like, but also kind of what do I enjoy about clinical neonatology. There are some practices that I got a sense didn't care so much as long as I was a body in the group. But to answer Catherine's question, I think it's hard to get that sense until you do your interview. But I know that our group wouldn't look down on somebody just even cold emailing the head of the group and saying, and just being honest that you have a personal tie. I know that was always seen as a plus. If you had a family member that you'd like to be closer to, that's a great anchor to kind of bring you to a group. So, I think casting a little bit of a net and sending out some emails and seeing who responds, and then you get a better sense as you go through the process. Hopefully that answered a little bit of that question.
If I can jump into that too, I think it's really easy to underestimate how small of a field this is. And even if you think that you personally don't know anybody, and using the example of California, I think if you were to reach out to your old co-residents, your co-fellows, and just say, hey, I really would love to know more about groups in this particular area. Does anyone have any contacts? Can anybody point me in that direction? I think you might be surprised at the connections you already have.
Yeah, I will emphasize that too. So, um, and it also works both ways. Obviously, when you've been doing it for a long time, it's pretty easy. You've been to so many meetings, it's pretty easy to find people all over the place. But even when you're starting out, going to meetings and using those as a way of connecting with folks from all over. But the flip is also true, and I try to use this to your advantage. Talk to people who, and emphasizing what Dr. Cruz said about everybody showing up at the interview is a really good sign. 2 or 3 people showing up is not a good sign. But the other thing is, I am going to, before I hire you, I will have talked to nurse practitioners and nurses that you work with in the unit to find out what you're like to work with. If you do the flip of that, if there's any way to get to talk to other folks that are, I mean, these NICUs are like either small towns or small families, depending on the size. If you can find a way to talk to the nurses and the nurse practitioners, and what is it like to work with this group? Are they fun? Do they, you can imagine all the questions out there, but that goes a long way also, I think.
I'll add one more thought that, when you only have a couple people show up to the interview, a lot of people have done transitions like we're doing right now. We've done this virtually. It's like a really easy way to connect a lot of people, especially across geography. I think stepping into those spaces, if you're planning to be somewhere for a while, is really critical to get a sense of how that interaction happens on site. So when the opportunities are there to visit places in person, I would take that up. I would see that as a sign of interest from both the employer, but also an opportunity to get to experience some of that interaction in real time. I think you can't either, I think it's much harder to see and appreciate that over a Zoom.
Yeah, thank you so much for all the insights. Our next question is, how might the initial email and cover letter look different when applying for a private practice job? as opposed to an academic position. As fellows, we have great examples of emails and letters for academic positions, but we haven't seen much regarding private practice inquiries. Dr. Koo, do you want to answer that question?
Yes, I would. Thank you. You bring up a really good question, but I want to say that even within private practice, your cover letter will differ from place to place, depending on the model of the private practice. Now, I am in a unique and going extinct model of a very small private practice of 13 neonatologists in an S Corp that has not yet been bought out by a large entity. And so we have a lot of flexibility, but also a lot of financial instability as well. I'm bringing this up because this differs in how you might want to pursue non-clinical work. So if you're going head into a job that's private practice because you know you want to be a 100% clinician where Monday through Friday you're more or less at the bedside, plus minus calls, plus minus weekends, depending on how many people are in your practice and how many beds there are, that's one route. Not all private practice is 100% clinical. Take, for example, at Sharp Mary Birch in San Diego, we have a full-time neonatologist researcher who we actually are an NRN site, and we do have NIH grants, et cetera. But that's a model that's possible because of how small our group is and how flexible we are. So basically, long story short is, if you are someone who's applying for a balance of research and some other career thing that you want to enrich. For me, I am pursuing informatics. So I am actually pursuing half-time clinical and half-time informatics, where the hospital, I'm in California, I cannot be directly employed by the hospital as a physician, but the hospital pays an admin lump sum to our neonatology group, who then pays me a salary. So now I'm able to do half-time admin in informatics, half-time in clinical. Basically, you just have to tailor your story and your cover letter and your CV based on every group.
Yeah, I think that's a wonderful point. I also remember looking back at my job search journey that I had to kind of tailor my letters depending on where I was applying. Next question is, do you anticipate proposed funding or Medicaid cuts impacting hiring? And I think that's a very important question in this political scenario. Maybe Dr. Horst can answer that since he is in the position to answer the best.
But we're going there, huh? That's very, so that is a very insightful question. That what does our field look like in the next 5-10 years, I think is what the question really is. Overall, the insurance companies are winning. So basically, there's a bunch of money out there for hospitals in general, not just NICUs. NICUs, however, get paid a lot more money for what they do. The number of RVUs that we generate, and I don't want to go down the whole RVU path, but one of the reasons why our job has been traditionally fairly easy and we've enjoyed fairly good compensation is because back in the 70s, 80s, it was Martin and a few guys got really good RVUs attached. So we can do something for an hour and we get paid more like radiologists than a pediatrician, where it suggests that we did a whole bunch. It's a dumb system, but it is what it is. So there's a bunch of money there, and every time there's a bunch of money there, then everybody wants to get more of it. And so the tension is the hospital is trying to get you to do everything. The hospital is trying to get you to do everything for free. The hospitals make a certain amount of money. The insurance companies are the ones paying for everything because of our third-party payer system, which we also won't get into. So all the money goes to them or the government, and then they pay you. And the insurance companies have figured out how to give away less and less of their money. And now with employment models and actually buying practices to buy private care, they're getting more and more money. The government, so our practice is probably 50-50 Medicaid and private insurance. When I anticipate that we will have more people who don't have Medicaid, and it's going to vary state by state. In Texas, they never expanded Medicaid, so we don't have as many, but it's still a lot of folks that are on Medicaid. I anticipate that we're going to have a lot more folks who don't have any type of insurance at all. And for that, we basically won't get paid. So It will, so speaking again, from a large practice standpoint, it will affect us. You get paid about 10, 20 cents, 10 cents on the dollar for what you bill. And what you bill makes no sense. That's a nonsensical number that you pick. And then you get about 80% or whatever you negotiate with the insurance companies. That's going down year over year. It never goes up. And then we're getting less of Medicaid's about the same. And and this is where I'll speak to a lot of the advocacy work that we do. It's a great place where it's a win-win. We advocate a lot in Texas at the state legislature to try to get them to pay more for Medicaid and to have more people enrolled in Medicaid. Regardless of that, it's still constant downward pressure on that. But the Medicaid does not affect you as much as the other. Having a bad negotiation with Blue Cross Blue Shield is going to hurt you a lot worse than having less people on Medicaid overall. It's still all very unfortunate and something that we're very concerned about, but it's not ultimately going to affect our compensation a large amount just because you're already getting so little money from that. Long answer, sorry. I think about that a lot.
Yeah, absolutely. Next question was, what if we don't yet know if we want to do private or academic neonatology? Maybe due to lack of exposure to private side. How do we balance timing of interviews, etc.? I'll let Dr. Smazal answer that question.
I think that's a really fair question, especially for those of you coming from large academic programs like I did. I will say I certainly wasn't discouraged from going into private practice, but it wasn't really talked about. I don't think that most of my attendings around me thought that I was considering that or thought to provide me information on that. I think the assumption was that I was going into, more of a research role or an academic role. And so I had to be a little bit more proactive in talking to people that were already in this role. And I think I speak for all of us panelists that if you would like to talk with us more offline about what our decision making process was like, we'd be happy to. But in terms of timing, I think certainly the earlier the better, like Dr. Horst already said. But at least speaking for my group, we would not look down on you if you weren't sure yet. And being upfront about what you're doing with the research, or excuse me, the research into your job search and that kind of thing, saying, I'm still deciding and I'm exploring a couple different options. My group would certainly not think that that is a bad thing. We would be open to you exploring your options. We would give you more time to make your decision. We would not be putting hard deadlines like we have to know by November 1st what you're doing, because we know that a lot of our best candidates might be looking at more than one job and might be looking also at academic jobs. So I think my overall point is explore it some more. We can connect you with people to talk to if you need that that as a resource. And two, I don't think it's a bad thing to be upfront with the groups you're talking to about that you're still early in this job search, that you're trying to make the most educated decision you can, but it's hard to do coming from a purely academic background. So I wouldn't want you to think that that's going to harm you in any way.
I would just add that I think it's really important to be genuine in your job search. So, like, if you have an interest in a particular geography or position for a reason, I think communicating that clearly, and it's okay to say, I have this other interest, I'm still exploring this interest or this, place, career path that might fit. I think nobody on this panel would say you should take a job that you don't want. Like, nobody wants to recruit people that don't want to be a part of that practice model. And so understanding what that is and what draws you to that is really helpful. And also being upfront about what things you're still exploring, I think, like Anne was saying, I think could be really helpful.
And Matthew, you did some time, am I remembering correctly from the intro, you did some time in academics before you moved on?
So my position's interesting. Anne was one of the fellows that was in the city that we were. So we have a lot of geography in Chicago, and so my faculty position's always been at the same place, but we have an academic partnership with the University of Chicago, and so I have medical students, residents, and fellows that rotate in our unit. But by the day, that's less and less as the training models have transitioned. But no, I didn't have a form. This is the same position I've been in for a decade. So no formal position in the academic center.
Yeah, my question was going to be to comment on, and as somebody who did, I wasn't sure, and so I stayed, which I still think was one of the smarter things that I ever did, because I really wasn't sure and I wasn't going to commit to a practice that I wasn't sure that I wanted to do. And I don't know that this is true, so this is personal bias, but I do think that it would be hard to go back to a university setting or go back into academics. Academic careers take so long to build, and the time cycles for grants and all those things are 5 and 10-year cycles. I think, I'm not saying it's impossible, but I think that's one thing to consider with an academic career, is what kind of academic career you might want. And it might be hard to go back and forth. I know people who have gone back, but usually back to work at community sites and those kinds of things. And I also want to know why I didn't get to interview Anne when she was coming out of Texas Children's.
I went right to Chicago during COVID. It was actually a really
Okay.
interesting time to be changing locations. I went to Chicago. My brother lives there. I was really happy to be there. But just in solidarity with all the trainees, you guys are coming out into just a crazy world. Things have changed so much. What with COVID and everything, and the hiring process, everything is probably a little different even than when I did it. So we're here to
Dan's
support
point,
you in all that.
Dan's point too, any fellow from Texas Children's or from Cross Street University of Texas, if they emailed me, it doesn't even have to be a good cover letter or anything like that. I'm going to talk to all of them and get to know them, and also be available, because I really see us as stewards of helping people find the right spots. We're not in a world where we're trying to trick people into working at a job they don't want to work at. I don't think there's anybody here that's thinking about that at all. So use those resources. I know it seems like we're kind of distant and far away and you're just this fellow, but we actually are interested in helping everybody get to the spots they need to be. So I spent a lot of time talking to fellows. I was looking on my files to see if I had one for Anne, because pretty much all of the fellows coming out of Texas Children's and UT, I have a file in their resume, and I've talked to them and try to help them figure out what to do. So we're all available.
All right. Next question is, what does your day-to-day workload on the unit look like as an attending in private practice? Are you responsible for notes, attending deliveries, putting in orders, etc.? And it says that Dr. Koo agreed to answer it live. So over to you.
I'm happy to answer this. Also, I apologize if my fat fingers hit the wrong button, but I am part of a practice that covers 3 different units, and all 3 units do things a little bit differently. So I could tell you a little flavor of each. At our main 80-bed unit, we have one neonatologist that's there for a 24-hour period with a nurse practitioner that helps that on-call physician. It's in-house call. So that nurse practitioner will help write notes, see patients, write orders, update parents, and then as a neo, you just do the quick cosign, examine the baby. We also have another level of help there called ALS nurses, advanced life support nurses, who attend deliveries and also do a number of procedures, not all of them, but many of them. And so basically at our 80-bed unit, we're very well supported, but I do still write a lot of my own notes and see a lot of my own patients. As you can imagine, being 80 beds with an average census of 60, between you as the neo and a couple of other neos who are just there for the day to round, plus your NMP, everyone still has to do their fair share of notes. At the community hospitals, which are a level 3 minus, and level 2, we only have ALS but no NNP. So you can imagine they can help with the deliveries and help with the some of the procedures, but they cannot write orders and cannot write notes. For those places, we round during the day, but call is from home. So you will end up having to go in if it's a more complicated patient to help with the procedures, and also if it's a brand new admission.
All right. So next question is, how does it work for private practice groups if there's a conflict with the contracting hospital? Like if the hospital system wants to institute initiatives that the group may not agree with, does there need to be a consensus or a vote? Is that an appropriate question to ask during interviews? Maybe I can pick on Dr. Pellerite to answer that question.
Sure. I mean, I think that the bottom line is, maybe we've talked about this in a couple different ways, but I think communication is really key to making sure that people understand what's happening and feel like they have a voice in the process that's happening. I think that oftentimes, I think the root of this contract or this question is, around like, I can't imagine that there's a scenario where there's something that truly can't be um, kind of explored and within reason answered. I think when those things come up, where that isn't happening, that's where contracts break down and physicians groups leave the hospital, which isn't in the hospital's best interest either. And so occasionally there's kind of the nuclear option, but I don't think that that's like the day-to-day pieces. I think that most groups that have a long practice at a site have ways to figure out how to bridge differences that do come up. That many people within a private practice may sit on, the professional staff, or within hospital leadership, even on committees and things like that. And so lots of those can be uh, solved. I think though that asking during the interview process, like when there is a conflict, like how is it resolved? What is the process? Who's the leadership that does that? What's the voice of the group? Those are all really reasonable and I think thoughtful questions around that. But I'm sure other people have different takes on that particular question.
I can speak. So I have a role that is a consulting role with HCA, which is probably, if you want to talk about the biggest, scariest hospital system of all of the big, scary hospital systems that might do silly things for the wrong reasons, it's probably the prototype. Though you probably, in smaller cities or in cities, you may have local hospitals that are prominent, and there's lots of different models too. I can say very definitively that they don't, and I haven't worked in any hospitals anyplace else where the hospital has ever asked us to do anything unsafe. Usually where they're weighing in is where they're picking up on a bad outcome and they're trying to fix it because they feel like they've got exposure, it's their hospital, and they don't want to put patients at risk. And that is typically a partnership. The main conflict would be if they're trying to fix it in a way that you feel is not the best, but I don't want anybody to worry about hospitals trying to get you to do bad care for financial reasons or something like that. I don't think I've ever seen that line crossed. It's usually something silly like HCA deciding that every baby in every unit has to get MRSA surface cultures done once a week, even though there's nothing to do about it. I'm working on that one, making that go. So it's usually stuff like that that comes up. That's just more of an irritant. Everybody's very invested. Everybody's very invested in the group being there. Typically, we don't have any place to work except for hospitals, so they do have some amount of leverage, but they just don't ever seem to cross those lines. And the physician management groups too, I will also say, typically don't ever tell you what to do. I've never seen that happen, being very involved pretty high up in pediatrics, for instance. And what they are all struggling to figure out how to monitor quality outcome metrics and be able to step in when things aren't going well. But there's not a lot of direction that comes around otherwise.
We did have a question regarding QI in private practice. And the question goes, my research primarily focuses on QI. I currently lead several projects and have presented multiple abstracts in this area. How can I find job opportunities that would allow me to continue pursuing this focus or that may value the expertise I bring in QI? Dr. DeCruz, do you want to answer that question?
It's a great question. It's a great fit for private practice, to be honest. I think QI is one of the types of research you could do in fellowship that, at least in my opinion, most closely ties with the majority of hospitals' focuses when they do when they have a private practice group employed. I think every hospital system and every hospital would like to get better at their craft and would like to see better outcomes. And we have, and within my group, we have a great kind of QI leadership with a couple of the more senior neonatologists who do a lot of our great initiatives, including starting a small baby unit recently with all new protocols. And we're doing a lot of cycles of data gathering. But I think talking about it on your interview and specifically how it links into that group. So if you do your homework on the group and you see that, maybe they're just lowering the gestational age in a certain unit, or that they might have a need to kind of work through a specific protocol, talking about what your interests are in QI and how you could do this and kind of work through it within their group would be helpful. I think one thing to keep in mind is just being clear on what you expect your extracurricular activities to be. So a lot of times within private practice, your clinical obligations are maybe a little bit more strenuous than they might be in an academic center. And knowing that, if you take on an extra responsibility, you want to kind of nail down, would you have that protected time to do it? Would it eat into some of your clinical obligation, or would it all be on you to kind of come up with the time yourself in your off days? I think that's helpful to nail down as you get through your interviews.
One of the next questions was, so as a fellow, how should I start thinking about discussing my experience? How many procedures have I done? How many low birth weight versus very low versus ELBW babies I've taken care of? And is that valuable when it comes to interviewing in the private practice setting? Maybe Dr. Smazal can answer that question.
Sure. I think I don't know that at least personally for my group, we wouldn't ask how many of each of those procedures you had done. I think we would assume that if you're graduating from a well-respected fellowship, that you're well prepared to handle most, and you're going to be put in all situations in private practice, certainly. And we would hope that coming out of a training program, you'd be well prepared to do those things. I think thinking about like interviewing and finding a job, I think one thing that might be important is thinking about how to market yourself a little bit and what your skills and your particular expertise might be in a way that works in the setting that you're applying for. And so what I mean by that is, like, say you have a very research heavy resume and you're thinking about applying for private practice, how can you translate that into something that's valuable to that group? And what is it about you is and in your fellowship that can make you a great community neonatologist? Mine was pretty easy. My research was all in nutrition. But I think if you looked at my resume, you would immediately see that I've spent a lot of time in surgical NICUs. And so it was on me to say, well, I'm really interested in nutrition and excited about nutrition. And the way that I see myself being an asset to the group is I'd love to be kind of the go-to person for new products on the market, new nutritional strategies, the new supplements, things like that we're doing. So thinking about how your expertise in QI research, whatever it may be, can work in this setting that you're applying for, I think would be important. But I wouldn't expect to be sat down and said like, hey, how many babies under 600 grams have you intubated? I don't think that's something that you have to worry too much about on an interview.
And to piggyback on that, the perfect example that I bet everyone's going to nod their heads to is anybody coming out with POCUS expertise or can do hemodynamics. You are at the top of the pile right now because we all need that and we didn't get the training. Oh, sorry, distracted by a baby. You, Jenny. Yeah, anybody. So that would that's what we're looking for right now. So we might even make a job for you if you came out and could help us learn how to do that and spend some time doing that.
I totally agree. I would lead with what you're interested in bringing, because that might not be something that the people on the other side of the table had thought about how it would fit into the group. But your unique skill set could be really valuable in a way that's not advertised in a position or noted in the blurb. But But I think anybody that has a genuine interest in care, I just like I think several people have said, I'm here to talk with anybody that's interested in a job and what that like might look like, and to dream through that scenario can be really helpful for both sides. So I would lead with what you care about and why, like Anne was saying, why it might fit in a context of that particular job.
That's really well put. I think to piggyback off of that as well, I think it does become really clear in talking to somebody if they have an interest in clinical neonatology. And I think what links everybody in our group is that we really love being with patients and taking care of the babies and interfacing with the nurses. And I think when you talk to somebody long enough, that just becomes really evident. That's all you have to really make sure of in your interview, is that you're getting that part of you out if you really have that interest.
Yeah, just to add my 2 cents is that when I interviewed about 3 years ago, and nobody ever asked me how many intubations I've done, how many I've been successful at, and things like that. So I would echo everybody that shared their thoughts. All right. So next question is, how does career advancement work in private practice? Are there defined milestones like in tenure track academia? And maybe I'll open it up with the two medical directors, and then the rest of the panel can also chime in.
So I'll start and say that we have a tiered employment system that's based on years of experience. And so as people acquire more experience, their salary is compensated at a higher level. There's also lots of opportunities for individualized advancement, whether that's like through some of the paths we've already talked about, taking out a role in something like QI, or a leadership role, like, director of some of the nurseries. We have both level 2s and level 3 nurseries. And so there can be kind of formal ways and informal ways that happened. But again, I think it comes down to that does look a little different for every person, and every position, I think, might look a little different.
I just finished redoing our org chart. We don't have them for everywhere, but we've got it for women's, where we've got 22 docs there and a bunch of different programs. And I was just commenting as I presented it to the group on Tuesday that it really just evolved from the work that people are doing to sort of create the role. So we have a QI director, we have an ECMO director, we have Kashif doing research. We've got a bunch of different roles. Somebody who just did so much work in the background with IT stuff and simulation, organizing our meetings, and a way to provide feedback, that I literally created a title. It's still awkward. If anyone's got a better idea than clinical effectiveness director, that's the best we've come up with. But the folks that do the work in private practice, it's a lot less regimented. And if you're doing the work, it'll come. If you need titles, I'll make a title for you. I think everybody does. Everybody needs recognition for what they're doing. I didn't mean that to be flippant. And then there's another tier of another pathway through leadership, which is being the medical director of all those various units. So all the units, the directorship of a unit sort of has a package of all the same stuff that you have to do at every one, regardless of the size. So my first job ever was at, I got up to Denver, and about 2 years after that, they knew I was interested in this kind of thing and gave me the directorship of an average daily census of 12 NICU, beautiful place in Colorado. And you learn all the same nuts and bolts. You have all the same committees. Everything's a little smaller. There's less problems that crop up, but the same problems crop up. And then as the units get bigger, it's still the same stuff. The volume of it just increases. So that's another good way to start moving through. And once you're doing that, you're on the hospital committees and learn all that kind of thing too. So starting as director of one of the units, I think, is a great way to head down that direction.
The next question that has come up is, would you mind discussing some things that bring you job satisfaction? Maybe Dr. Koo can answer, and maybe after that, Dr. DeCruz.
Sorry, did you call on me? My baby's saying.
No worries. We were asking, what are some of the things that bring you job satisfaction the most?
Yeah.
Yeah.
I'll echo what Ravi said before is bedside time. I truly love my time at the bedside. And I don't mind writing the notes, being the one to update parents. And that's what's special about private practice in a lot of models where you are the front facing person. If anything, I prefer that over the academic model where I have to be the fourth in line, and the fellows get to interact and they get all the procedures. No, I get the full, like frontline exposure. And I do have enough support where if I wanted to back off a little bit, I can. And the NPs and ALS nurses can do that. So that's one of the things that bring me joy.
Yeah, I love that answer. I think uh, that's sort of answering it on the micro level, like on the day to day. And I think similarly, that flexibility that Jenny's talking about how much involvement you want. I think on the macro level, having some control over your schedule and how much you work and controlling your FTE, I think that is really helpful for work-life balance, because I think one of the things that's really important to know is that life changes quite a bit, and sort of what you're able to give your job changes, and what you want to give to your job changes. And I think you get so conditioned when you're going through training that you have to give every 99% of your soul to this career. I think it's hard when you reach the actual job itself and you realize that that might not necessarily be true. And maybe you want to start off at 1.0 FTE, and you have a certain amount of time off. I know when I started this job, I was at 8 weeks off a year, and I really quickly realized that for my partner and I's schedule, that just didn't work very well for us. So it was just a quick conversation with my boss to say, can I, up it to 12 weeks off a year? And I think he replied within a minute. He's like, absolutely, whatever you need. I think that really helps overall satisfaction, because I'm able to dedicate more of myself when I'm there to the job. And then I think, just again, overall balance. I think everything's all about balance. Being able to kind of shut off and have a rough clinical day, but then not have to think about anything once I reach home is a real blessing for me. I love being able to work hard when I'm at work, but then when I'm home with the kids, I'm just fully invested in being a parent.
Yeah, that's excellent points on what brings you joy. Dr. Smazal, maybe I'll answer. I'll have you answer this question. What are the typical contract lengths, and is there an availability of less than 1.0 FTEs?
Sorry, I was muted. I think that's going to vary a lot by your practice. I think that the contract length is certainly going to be individual to your practice. The FTEs is also going to depend on what the group needs. If they're hiring multiple people and have various setups for that, maybe that's something that's available. For my group, we sometimes will have people who we call it job sharing. And the way that that would work, because my group so highly prizes continuity with our patients, we have primary patients that we may be quote unquote responsible for throughout their admission. That doesn't mean we round on them every day, because that's certainly not feasible, but we would be kind of the primary decision maker, kind of guiding them throughout their maybe prolonged hospitalization. And so having people take kind of co-primary patients is a way that we job share, knowing that that keeps the continuity high for that patient. So that's a way that we kind of offer less than what would be considered a full-time FTE, I guess. So I think that's something that could come up more in your discussion with each individual job. I think that's going to be so variable that it's hard to know at this point.
And I think what's happening is the idea of what an FTE is changing. So
Yes.
certainly what an FTE was when I came out in 25, 26 years ago was very different. I actually was the guy who turned into an attending the day when the residency rules kicked in, July 1st, 2003. So what I've noticed and is, and this is not a kids these days comment. It's just that I think it never should have been the way it was before. It was absolutely crazy the amount of work that we did. So as an FTE has changed, I think groups have become at least the groups that want to hire good people and be happy are learning this. I just had 3 docs to speak to the job sharing that you were talking about. I had 3 docs come to me and say, we want to take up 2 FTEs. And I'm like, great, that works perfect. Keeps things even too, which helps people. So we think a lot about work-life balance in ways that we didn't before. And I will also speak for pediatrics and say that the contracts typically don't have a defined period anymore. When you're going with the actual group where maybe you get like a 3-year contract and then you get partner after that. And again, if you're going with a group that has their own equity, make sure that that's a discussion that you have. But for the most part, the contracts, and I can speak to most of the hospital ones too, it's not a defined period of time. It just evergreens every year. And then it's going to be practice dependent, but much like yours, we have a salary ladder that just goes up for the first 10 years because we decided we didn't want to get into the business of, you're a better negotiator or you have more leverage, so you're paid different. So we start here and you go up over 10 years to the top of the ladder over 10 years. And so it's not the same. If you're going with a private group that still has their equity and there's 10 people in that group, I think it'd be a very different type of negotiation. Definitely the other thing I was going to mention, I didn't mention on slides, is have a lawyer look at your contract. No one's going to be offended that you do that too. The lawyer will look at it and they'll want to change way more than they'll be able to. Don't be surprised at that too. I go through this exercise several times a year. The lawyers, I'm like, I know who paid more for the lawyers too. The ones who pay a lot for their lawyers, they're like, this whole thing is, don't sign any of this. And then spend some time. That's an opportunity then to talk through what you can and can't do and where but do have a lawyer look at it. I am not going to be impressed I'm not going to be offended. I'm actually not somebody that just signs the contract without looking at it. I'm going to be thinking, whoa, wait a second, what did I just do? Because you may be negotiating something for me one day. So anyway.
I couldn't agree more with all of that. As someone that's married to an attorney who does immigration law, and she would say that if you have someone that's not a contract attorney review your contract, it's like having a cardiologist do your colonoscopy. Like, make sure that you have a contract attorney do that. And like any big organization, there's likely to be language that they'll want to leave in, but you should know what that says and what it means, and that's the part of the process that you're paying for. But it's great.
Why do we have to leave it? It's true story. Last go around, I've been doing this again forever. Last go around, Ben brought his contract in and he was showing me these comments. I'm like, man, this is a good lawyer. That lawyer actually found something I brought back to pediatrics with an ex-leadership national, and they're like, he's right. That doesn't make any sense. We have to change that in our boilerplate. Like, that refers back to a double negative. We can't have that.
Yeah, and then I saw that someone had asked about workforce, the new publication. I was going to mention that, when you were talking about this, Dr. Horst, about what an FTE is, I have been out of training a little bit less time, a decade, but we've changed what we've called an FTE even within our organization here, like how many hours that really means. And there's a new working group through the AAP, the SWAN committee, that's supposed to bring out a report about a clinical FTE that I'm eagerly anticipating, and I think many people are, about what that means. But I think in our current landscape, many people define what a clinical FTE is a little bit differently. And so having clarity around that, what is included, what isn't, to the conversation we had earlier, like if your, other pieces of your work are going to be included in that, like quality or committee time, how they're accounted for in those models too is helpful. And so those are good questions to ask each site.
Yeah, I'm happy to report that we convinced them that they needed private practice representation on that, and that's going to be me.
That's great.
Excellent. Kind of piggybacking off on this same topic, how do you discuss loan repayment in a private practice job interview?
I see that the person who asked the question specifically asked about PSLF, and I think that's certainly a fair question and one that's super relevant for those of us, which is going to be a lot of us coming out of all this training with all these loans. So I think it's very fair to ask if your job is PSLF eligible. And then I think it's worth doing the math because my job isn't for first and foremost, but the difference in what I would make in an academic setting versus what I make in my job makes it, you know, it it is well worth that giving up that benefit, I guess, giving up that PSLF possibility. Um, so I think there are a lot of ways to think about that and being careful and that you're not giving up. I wouldn't want you to rule out a job just because it's not eligible, is what I'm trying to say. It may end up being financially to your benefit to give that up anyway. So.
And then maybe this is a personal question, and then I'll again open it up to everyone. As a senior attending in the group, what are the challenges that you see that are different from a senior attending in an academic center versus a private academic group? For example, is there a pressure for you to have more patients, more production, more patient satisfaction in a private setting as compared to academic setting?
I can answer that as somebody who's worked in both settings as an attending. It's very similar. The workload has, and again, I'm only speaking to being attending at Texas Children's in my practice now, but similar size units. It's very similar. When I talk to parents about, I can see Texas Children's out my window. So we have a lot of discussions about, families that, should I be there? Should I be here in this setting? And what I describe to them is it's pretty much everybody does a good job at all the places. Here, you're going to be talking to me at a university setting. You're not going to see the attending as much, but you're going to have a ton of people talking about what's going on with your case. We do that too, but in a different way. And the biggest difference for me was when I was an attending at Texas Children's, I really was not engaged with the families. I was engaged with what was going on with the case. I had a lot of people doing all the work for me, but I needed extra time to go back to the lab and do all this. My days are just as full either way. I don't have the teaching or the research responsibilities that I had before, and that kind of gets filled up with direct patient care. But the workload is fairly the same. And we do try to even that out in all of our settings across all of our practices too. It goes from seeing a patient or seeing a group of patients with no NNP, and we cap that out at like 12 to 15 and certain types of patients too. And you can get through that in a day. And if we are making things harder during the day, we're doing it just like Dr. DeCruz said, we're doing it because the group has decided that we're going to work hard and have more time off. But those are all group decisions too. There's no real being pushed to grind out a bunch of FTEs or see more patients than you need to. I think that really lives more in the outpatient environment where they're having to see 30 patients a day. I think that's where a lot of the dissatisfaction is. I know pretty much what's going on in the majority of practices in pediatrics and other places. And I just don't really see that very often, that we're being forced to work harder than it's usually in a situation where there's some benefit that you've made the choice to do that. If you're in a group that has their own equity, you're going to be making decisions about how many people, how much money you want to make versus how many people you have versus how many patients. So those are group decisions that you make too. So I haven't seen that be a real stress point. I mean, everybody works super hard and our job is hard, and that's all true. But I love that I put 2 chest tubes in yesterday and intubated somebody. I still get to do all the stuff, and I love, and I'll shut up then. I haven't answered this yet. My favorite thing is just that I get to talk to the families, and they come to our hospital because I want them to be taken care of like I would take care of any of my friends or family's kids, and I get to meet them and they become my friends, and I just love that direct contact with the families and then getting to do all the stuff too.
I love that answer, and I would just add that there's hard. I would say the description of hard is relative. So things that I prefer not to do, some of my colleagues like love doing, and so understanding what that means, I have a different brain capacity for level 2 coverage that is different than some of my colleagues who are like, I would love to take more time there, so I openly say like, take it, like this is great, like if you want to do that. So I think that understanding what is hard, what you mean by hard, or what is hard for you, to try to limit that, and recognizing that in any position there are things that you'll be asked to do that are not your favorite parts of that job, and so understanding that that's a part of all work, but that where you can limit those pieces that you aren't getting joy from. I think that that's a great workplace that can be responsive to that. I think Jenny, you were trying to say something and I jumped in, sorry.
Oh, no, not at all. I wanted to piggyback on the flexibility of some of the smaller groups who haven't sold their equity. For instance, at our group, we do have an age dichotomy where some of the younger folks with small children at home prefer a little bit more home life, and want to decrease on the clinical a little bit, whereas some of our more experienced partners prefer to have more call, and they're able to do more call because they want the higher income. And so when we have discussions like this, it comes down to how many do we hire, how do we redefine an FTE, and how many calls does an FTE mean. This conversation is constantly ongoing as people retire, and we're questioning whether or not we should open that FTA for hire or just spread out the work amongst who's already here, existing in the group. And there's always the option, as Ravi had pointed out, maybe the full FTE definition doesn't change, but your amounts of FTE, you could maybe bring your FTE down to 0.75 and adjust as needed to make sure that you have that balance in life. For me, I'm seeking balance by decreasing clinical and increasing informatics work, because informatics work is done at a computer where I could potentially do it from home and still make it to my toddler's dance class. So uh, there's a lot of flexibility in some private practice models.
And I think that could be a really good question to ask on an interview is, how does your group handle flexibility, thinking like on an annual basis or things like that, where people may be having children? How do you handle maternity leave? How are you handling, things come up. I had a partner who, I think he tore his ACL on a ski trip, and all of a sudden he can't be on his feet rounding all day. So how do we as a group immediately cover that? Versus even just day-to-day things, or week to week. We had a unit that typically has a census of about 20. Over the course of 3 months last year, for whatever reason, the unit just exploded and it was closer to 40 most days. And how did we shift our scheduling? How do we shift our practice to account for that, and the ways that we help each other, and the mechanisms that we have both built in and kind of on an ad hoc basis? Exploring those in an interview, I think, is going to be a great way to get to know the group's culture as well. So that might be a good thing to ask.
Yeah, those are all excellent points. Next question is, maybe this is more relevant for some of our newer attendings in the group, on the panel. What do you wish you knew to ask for when interviewing and negotiating your first contract? Maybe Dr. DeCruz, and then Dr. Ku, and then maybe Dr. Smazal.
It's a good question. Yeah, I think, talking through pediatrics contracts, a lot of it is pretty boilerplate, and I did have it reviewed by a lawyer, as Dr. Horst suggested, and it came back to my boss, who said none of those changes could be made. Some of the things are going by the wayside that are a little interesting are, within the greater Seattle area, there is Seattle Children's / University of Washington, and then there's our group, and we kind of split all of the hospitals in the greater metropolitan area. I actually worked for Children's for a year before switching over to my private practice, but I was fortunate in being able to do so because my first contract did not have a non-compete in it. And I think looking through your contracts and seeing whether or not you have the ability to change jobs within a geographic area is helpful, just because I think the idea of uprooting my family and moving somewhere just because I wasn't fully happy in my job would be really difficult, and it only becomes more difficult, as you grow your roots in a certain area. So I think that's one thing to look at. How ironclad is the non-compete, if there is one? Do you have other options? Um, and I think, one of the things that was interesting to look at for me was a carve out for. I had a device that I designed for holding babies for LPs, and I created a carve out in my initial contract to protect that intellectual property. That's something to look at in an early contract. If you have some sort of thing that you don't want your medical group to basically have ownership of, and you want to retain ownership, the only time to really protect it is in your initial contract, because I think I can't imagine the process of going through and having pediatrics be able to not own this product later on would be pretty onerous. So I think those are two things to look at, but those are very specific to me and what I looked at. I'm sure others have some other things that might be more useful to the majority of people.
I think one thing I would think about that might be more relevant for places that do home call is whether you have any kind of geographic restrictions in your contract. So if you're taking home call, most places are going to require you to be able to be in-house within X, half an hour, 1 hour, whatever it is. So if you're moving somewhere new and you're not sure what the traffic is like, or if you're going to stay in that neighborhood forever, make sure that that's kind of something that you have either some flexibility on, or you can figure out a way to be flexible later on. Um, and then one thing that I kind of look back and laugh, it was only 2 years ago that I started this job, but I remember being incredibly bashful and scared and nervous to ask about our equivalent of a signing bonus. And I was kind of like, oh my gosh, they're going to think I'm all about the money. And like, that's not the vibe I'm trying to put out here and all these things. And it was very stressful for me to make the transition, moving out of my place in Chicago, moving all these things on, a fellow salary. It's not very much. And I think that looking back, I'm like, oh my gosh, everybody in my group would have been like, of course you need a signing bonus. Of course she needs a little bit of money to move. So I think being upfront about what will make the job work for you, and if that's an extra whatever amount to help with your moving expenses, or an extra signing bonus to kind of gloss that transition in between earning your fellowship paycheck and getting your first attending paycheck. I think that you can certainly be upfront about what you need, and many groups would be happy to accommodate that. So please don't be shy or bashful about asking for signing bonuses, moving expenses, that kind of thing.
I want to say that I wish I had laid out how you can do extracurriculars, well, outside of clinical work, like side things like research or QI or admin work, well in advance, because I ended up doing a lot of pro bono work on my own free time that was basically not compensated because it's non-clinical time and it's not protected time. Our clinical FTE is basically Monday through Fridays. You're constantly on. There's no off time unless if you're taking PTO. So just be careful of that. If you are really passionate about QI or research or whatever it may be, see how you could be protected well in advance.
And if I can add my 2 cents, know when your contract starts, because that's when your health insurance coverage and all the other things that come along with it get started. It just happened that we had 1.5-month-old baby when I started my fellowship, my attendinghood, and for some period we did not have health insurance coverage from my previous job between and then the new job. So then we had to buy based off of the marketplace. So definitely know that for sure.
Yeah, quick add on non-competes. It's very difficult. That's going to be one of those typically non-negotiable things. The one area where there has been a little bit of negotiation to do is a carve out for an academic center in the city. So I've seen that happen a few times, depending on the situation, where especially if that academic center isn't the primary competition, if you think you may want to go back, and we've had people go work at the county hospital in various places or go back to work in a university setting. That's not really what non-competes are intended for, but having that, if you think there's any possibility, having that sketched out ahead of time. I still can do it, which I wish when I came back to Houston that I would have carved out TCH in case I wanted to do something there at the very end of my career, like all those people you saw rattling around there, and it's still working because it's a great institution. I love it, and they're still all my friends. And it might be nice to just have a half-time job there, hanging out at the end. But I didn't carve that out. I know some people did that and were able to do that.
All right, I think that brings us to the end of this session. Nicole, did you have anything else to add to this discussion? I'll bring up the last slide of the PowerPoint, which is going over the code for our next session that is happening on June 12th between 3 to 4:30 p.m. It is about academic practice webinar. And then the one after that is on July 21st, Monday, from 4 to 5:30 p.m. And that is interviewing an early career panel. We sincerely thank all of the panelists and especially Dr. Horst for the didactic session. It was very helpful. Thank you so much for everybody joining. And Nicole, if you have anything else to add, I will leave it up to you.
No, awesome. Thank you guys so much. If you are attendees, if you have time, please fill out like the 2-minute survey for feedback to make sure that we're giving you what you need in these sessions. So thank you guys again. Thanks to our panelists and our speakers for being here today. This was fantastic.
Thanks for having me.